Okay, thank you, Dr. Samir. We'll move to the second part of session number 2. So we'll have Dr. Mohsen Al Zahrani. He is going to present 2 abstracts. The first one is BIT adaptive therapy in bulky stage 1-2 classical Hodgkin's lymphoma. And the second abstract will be a prognostic score incorporating MTV predict treatment failure in advanced Hodgkin's lymphoma. Dr. Mohsen Al Zahrani, he's a consultant, section head division of adult hematology and cellular therapy, Department of Oncology, King Abdulaziz Medical City, Riyadh. He's also an assistant professor in King Saud bin Abdulaziz University for Health Science, Riyadh. Dr. Mohsen, the mic is yours. Thank you.
Assalamu alaikum. Good evening, everyone. Thank you, Dr. Muhammad, for the introduction. And I would like to thank also the organizing and scientific committee of SSPMT to invite me to present in this conference, to present 2 studies from 16 ICML highlights. So the first study that I'm going to present was presented by Dr. Anne Lakaska, which is CALGB 5081 Alliance BIT adapted therapy in bulky stage 1-2 classical Hodgkin lymphoma. As you see in the table, these are 4 randomized BIT directed studies in Hodgkin lymphoma that included patients with bulky disease. Most of these studies include unfavorable stage, early stage, or advanced stage Hodgkin lymphoma. If we look to the group with the BIT2 negative in each study, which is this slide, the second slide will be showing the BIT2 positive studies. The ECOG study randomized patients to ABVD times 6 plus radiation therapy versus Stanford 5 plus radiation therapy. All patients had bulky disease, and the outcome was better using ABVD plus radiation therapy. So we know the ABVD plus radiation therapy, or ABVD in general, is better than Stanford. Russell study, 119 patients with bulky disease from 1,203 recruited in this clinical trial. The escalation of therapy to AVD, de-escalation of therapy to AVD times 4 with no radiation therapy did not affect the outcome in those patients to 91.5% BFS. The EORTC H10 study, 515 patients. There was bulky disease out of 1,196 patients. 375 had BIT2 negative, and no radiation in the non-radiation arm has similar outcome to those receiving radiation therapy. So omitting radiation in the BIT2 negative arm did not affect the outcome and has similar BFS to those who received radiation therapy. In HD17 study, 199 patients with bulky disease, removal of radiation therapy also did not affect the outcome. So we see from this studies that BIT2 negative studies showing that omitting radiation therapy may not affect the outcome and will reduce the toxicity. Regarding classical Hodgkin lymphoma with bulky disease and BIT2 positive, we have 2 studies, the EORTC H10. Again, 515 patients had bulky disease and 140 of them had BIT2 positive. And the escalation of therapy to ABVD plus escalated BICOP plus radiation therapy resulted in outcome almost similar to BIT negative with excellent outcome, 91%, similar to those with BIT2 negative. In HD17 study, 199 patients in total with bulky disease and BIT2 positive had low BFS despite giving radiation therapy to chemotherapy arm. So this indicates that BIT2 positive is associated with the worse outcome. but the escalation of treatment may improve the outcome of those patients, and we should include radiation therapy. In a previous study of Alliance group, which is 50-60 for stage 1 and 2 without bulky disease, the BFS of BIT2 positive arm at 3 years was 67% compared to 91% in BIT2 arm. However, radiation therapy is associated with late toxicities, and previous studies BIT directed is associated with progression-free survival outcome. The hypothesis in this study of classical Hodgkin lymphoma, this study with bulky disease, is to study the de-escalation of therapy in BIT2 negative with removal of radiation therapy and escalation of therapy if they have BIT2 positive. The escalation is with escalated backup plus radiation therapy. This is the design of the study. They start with ABVD for 2 cycles, then they do BIT2. And if BIT2 is negative, there is no radiation therapy, and they will continue with another 4 cycles, total of 6 cycles ABVD. If BIT2 is positive, 4 cycles escalated backup will be given plus radiation therapy. And the eligibility criteria is limited stage disease, plus bulky tumor defined by mass more than 10 centimeter or mediastinal mass more than 1/3 maximum intrathoracic diameters on chest X-ray. Primary endpoint was the BFS. The calculated sample size was 93 patients. Final analysis after all patients had been followed for at least 3 years post-study entry. 100 patients enrolled. 92 patients completed 2 ABVD. 73 patients or 78% tend to have BIT2 negative and received additional 4 cycles of ABVD with removal of radiation therapy. 21 patients or 22% of patients had BIT2 positive and received the escalation treatment, which is 4 cycles escalated backup plus they added radiation therapy. These are the patient characteristics were similar in both arms. If we look to the stages of the disease, the study included both favorable and unfavorable patients. Regarding pulmonary toxicity secondary to polymyxin, 70 and 76% of patients respectively received polymyxin for a total of 6 cycles in each arm. Pulmonary toxicity were similar in both arms, none with grade 4 in both arms, none with grade 3 in escalation arm, and more cases of grade 1 to 3 in ABVD arm. Hematologic toxicities, febrile neutropenia, and sepsis, as expected, were more in the escalation arm because we used the escalated backup, but no death is related to this. The BFS at 3 years was 90% in BIT2 positive in the escalation arm, and 93% in BIT2 negative, and those patients who received standard arm 6 cycles of ABVD, with hazard ratio of 1.03. Overall, survival was similar in both arms, 94% in BIT2 positive and 99% in BIT2 negative. 1 death in BIT2 positive was secondary to pneumonia and lymphoma. 3 deaths in BIT2 negative were secondary to lymphoma, anaplastic astrocytoma, and COPD. So in conclusion, this was the first prospective study limited to bulky stage 1 to 2 classical Hodgkin lymphoma. BIT2 adapted therapy was associated with excellent BFS in all patients. 78% of patients did not require radiation therapy or exposure to escalated backup. Unexpectedly, BIT2 positive patients with bulky disease appear to have improved outcome compared to stage 1 to 2 patients with non-bulky disease in the Alliance 50-64. Maybe the explanation for this, the small number of patients included in both studies, especially the non-bulky disease, and the use of 4 cycles of escalated backup in the bulky study versus 2 cycles of escalated backup in the non-bulky study. Limitations of this study is small number of PIT2 positive patients, as you mentioned, 21 patients. The non-randomization recommendation is to omit, as a conclusion, recommendation is to omit radiation therapy in PIT2 negative patients who receive 6 cycles of ABVD. Is safe, and this has been shown in other studies. Future directions is comparison of future studies incorporating novel agents with respect to efficacy, safety, and cost. So this is the conclusion of the first study. Thank you. And this is the slide from the presenter and the Alliance group. If you agree, I will go to the second study.
Yeah,
so
go
this,
ahead.
Okay, thank you. So the second study is the new prognostic score incorporating metabolic tumor volume, predicts treatment failure in advanced Hodgkin lymphoma. This was presented by Dr. Barrington on behalf of Rathel and Swag investigators from UK and USA. This slide is the disclosure of the presenter. As a background, metabolic tumor volume is promising biomarker for assessing prognosis at baseline in Hodgkin lymphoma. In this study, they hypothesized that the risk of treatment failure in advanced Hodgkin lymphoma might be assessed more accurately by incorporating BIT metrics with clinical factors to guide initial treatment at baseline. This study is well known. The Rathel study included patients with advanced Hodgkin lymphoma were treated with 2 cycles ABVD with randomization of patients with negative BIT scan to ABVD or AVD by omitting bleomycin. This is the de-escalation arm, and treatment escalation for patients with positive BIT scan to PCOB chemotherapy. The escalation with AVD was non-inferior to ABVD as a conclusion from this study. Baseline clinical and BIT characteristics were evaluated in the UK Rathel population, including metabolic tumor volume, total lesion glycolysis, and various SUV metrics. Patients were divided into training and validation sets in a ratio of 2 to 1. A Hodgkin lymphoma event was defined as a positive interim BIT scan at cycle 2 of ABVD or relapse after a negative interim scan. They explored the association of clinical and BIT factors with the risk of a Hodgkin lymphoma event using bootstrapping with Cox regression and receiver operating characteristic area under the curve analysis 5-year event to drive a new prognostic score. 1 patient died before BIT2 due to Hodgkin lymphoma included as an event. 1 patient died before BIT2 with cardiac cause of death and was not included as an event. 17 patients died after BIT2 negative scan without relapse and death thought unrelated to Hodgkin lymphoma and were not included as event. These are the 25 parameters they evaluated. For BIT, they measured the maximum SUV, MTV, and TLG of the total tumor and the bulkiest lesion. They used 2 SUV threshold to outline tumor and locked site of extranodal involvement on BIT CT. The clinical factors were components of the IBS, bulk, B symptoms, and BS. The training set included 521 patients. The final model included MTV outlined using an SUV of 4 or greater and lymphocyte as percentage of total white cell, both as continuous variables and stage 4. The area under the curve was 64.8, indicating moderate accuracy. The hazard ratio of 1.89 indicate that for a unit increase in score, there is nearly a doubling in the risk of a Hodgkin lymphoma event. They choose the 30% of patients with the highest score in the training set to be the high risk group and the remaining 70% to be the standard group, as this cut point was associated with acceptable risk for treatment escalation at diagnosis. Using this more clinically relevant cut point, the Hodgkin lymphoma event rate at 5 years which included patients with a BIT2 positive scan was 22.1% for the standard group and 45.4% for the high-risk group with a hazard ratio of 2.4. The new score had a sensitivity of 47.7% and a specificity of 76.3% to detect a Hodgkin lymphoma event by 5 years. It discriminated the risk of a Hodgkin lymphoma event by 5 years better than IBS, which had lower sensitivity and lower specificity and incorrectly assigned more patients to the high risk group. This table shows the expected outcome of 1,000 patients treated with Arathel approach at 5 years. 42% of patients would have a Hodgkin lymphoma event if considered high risk using the new score, compared to 36% of patients considered high risk using IBS score of 3+, which is the high risk group. Conversely, 81% of patients would not experience a Hodgkin lymphoma event if considered the standard risk. The new score compared to 74% considered standard risk with the IBS of 0 to 2. The standard risk patient had 5-year BFS of around 85%. The high risk group of around 70% and 80% for the whole cohort. The standard risk group had comparable BFS to patients in the BIT-driven arm of the AHL 2011 study treated with escalated BICOP first line and de-escalation after 2 cycles to ABVD if BIT negative. Combining the new score with IBS provided no additional information as you see in this graph, and the new score model arm dominated over the IBS arms. The score derived from the training set validated internally in the Arathel database, as you see in the graph, with similar results in the training set and the validation set in for both the standard risk and high risk groups. They did external validation in the SWOG 0816 study, which had a similar trial designed to Arathel, but included only stage 3 and 4 patients. So in the SWOG 0816 study, they treated patients with 2 ABVD and then they do BIT2. If they have BIT2 negative, then they give 4 cycles ABVD. BIT2 positive, they escalated the treatment with 6 additional cycles of escalated BICOP. They compared the result of the new score and its association with the Hodgkin lymphoma event in patients with stage 3 and 4 in the Arathel training set and the SWOG data. The score validated in the external independent database with the result as shown that were closely aligned with the Arathel and SWOG 0816. As you see in the graph, the result is similar for both studies in the training and the validation, external validation set in the SWOG database for both the standard and high risk groups. So in conclusion, a new prognostic score incorporating a metabolic tumor volume could identify patients with advanced Hodgkin lymphoma in whom more intensive therapy than ABVD would be useful at diagnosis, whilst avoiding escalation for those with high chance of cure with ABVD alone. As the score is continuous, cut point could be changed depending on the proposed therapy and risk-reward balance for over or under treatment. This is the acknowledgement from the presenter. And this is the, thank you very much. I'll be happy to take any questions.
Okay, thank you, Dr. Mohsen. We'll see if we have any questions from the audience. Okay, so it seems to be there is no questions. Can we use this prognostication like MTV in early Hodgkin's lymphoma?
Yes, it can be used, and as the training set included in the Rethel study, it can be used in the early stage Hodgkin lymphoma, but the details of the measurement for the early stage disease need to be studied carefully, and we need to wait for the manuscript of this study to see how they measure the metabolic tumor volume and other parameters to identify those with standard risk versus those with high risk.
Okay, good, thank you. So from your experience, like escalating the treatment after PET positive, after second cycle of ABVD, have you had like an experience the tolerability of chemotherapy if you have PET positive after second ABVD in terms of toxicity?
Yes, this is actually our practice at National Guard Hospital in Riyadh. After 2 cycles ABVD, if there is still PET positive with no significant response, usually we escalated the treatment to escalated PCOP. And we have reported this in a manuscript, and the escalation of treatment has shown that there is an improvement in those PET2 positive compared to those who did not receive escalation of treatment.
Good. Long-term toxicity, any update, any data you have?
Similar to, not different from those who are treated with escalated PCOP. We did not study this, we did not present it in abstract, but from our practice, we noticed similar toxicities regarding hematologic toxicities and other toxicities.
Okay, what about the new agent like brontuximab based regimen if PET positive?
This depends if there is clear failure of treatment like refractory disease or failure to treatment, there is like disease progression after 2 cycles. Those patients, they failed the treatment. So we take them to salvage treatment, which include second-line chemotherapy. And our practice is to add brentuximab to second-line treatment, followed by autologous transplant.
Thank you very much, Dr. Mohsen. If no questions, I think we're going to conclude this session. Thank you, Dr. Mohsen, for informative presentation.